All right. Just make sure this is up and recording. Okay. Hi, guys. My name's Jason Kofed. I am currently studying in the Utah Vascular Research Lab, and my mentors are Russell Richardson and Ryan Broxman. And for my presentation today, or for my research proposal, I'll be talking about our study, which will be the comparison of in vivo and ex vivo assessments of vascular function. So, quick background on vascular function and why we care about vessels. Oxygen is key for our bodies. Obviously, we know we need to breathe oxygen and that's important. But the reason that we need oxygen is it's a key component in our energy production. Everybody's heard the phrase, the mitochondria is the powerhouse of the cell, but the mitochondria cannot produce energy in a sustainable way without oxygen. When there is a lack of oxygen, our body does switch to alternate methods, but these alternate methods create metabolites, things that will cause fatigue and that they are unsustainable. So what's important is being able to get oxygen to the mitochondria and then getting the mitochondria to be able to process the oxygen to allow that production of energy. One of the ways that we can help increase that is to increase the delivery of oxygen, and that's where arteries come in. Arteries are what are that main control in blood flow, and so if a muscle is exercising, a vessel will dilate to allow an increased amount of blood flow to go to that muscle, which would then mean more oxygen delivery and the muscle will be better. Now, this is very easy to see the benefits when it comes to people in exercise, and that is something that we do care about, someone's ability to perform exercise either for daily function or for high-level athletes. But one of our bigger concerns is the causes of fatigue and those that, whether it's symptoms of disease or symptoms of aging, they tend to see higher fatigue and to see a decrease in that blood delivery and utilization of the oxygen. So arteries can become dysfunctional. You typically see dysfunction with age and with disease, as said before. But what defines the dysfunctionality is their inability to dilate. So if they aren't able to dilate or contract and control which way blood flow is going, then there's going to be a decrease in blood flow to the necessary muscles, or as well as the heart or the brain, which can cause many diseases, cardiovascular diseases such as heart attacks or strokes. It can also cause that increased fatigue as talked about and many other things. So looking here, we have a little anatomy of the artery. To run through that real quick, we have a hard outer shell that we're not really going to worry about today. Then you have this middle layer. Let me get my laser pointer out, sorry. So you have the hard outer layer. In the middle, you have the muscle layer, known as the tunica media. And that's smooth muscle in there, and that's what's going to contract and relax and control that size of the artery. And then on the inside here, we have the endothelial cells, known as the tunica intima. And this is just one layer of cells. And you'll hear me use the term endothelium a lot. When I use that term, it's talking about these cells. So dilation can occur in two ways. It can either occur by direct stimulation of the muscles, and that's called endothelium independent because it's going straight to the muscles. It's not worrying about the endothelium. And so that can cause an immediate relaxation of the muscles despite any functionality of the endothelium. But then probably the more physiologically important one is the endothelium dependent dilation. What happens is some sort of signal will cause these endothelium cells to secrete local vasodilators or chemicals that are going to go to the muscle and cause relaxation. So we got those two types, the endothelium dependent, which uses the endothelium, and endothelium independent. So in my study, I want to be able to, there's multiple ways to study arterial function and vascular function. And a lot of this study is going to be directed towards validating these studies. and being able to help make transitions for treatments and other things like that from the lab into a use on a human. So quick definition, ex vivo means out of the body. So if we were to dissect an artery and then go and study it in a lab, that would be ex vivo, whereas in vivo would be studying it in the person themselves without any kind of dissection or taking things out. So ex vivo and in vivo use those terms a lot as well. Our measurements that we have for ex vivo is flow-induced shear stress. I'll explain those, the ex vivo here now. Flow-induced shear stress is increasing the flow in the artery. That's going to cause a signaling to the endothelium, cause it to increase or to dilate. Then we have endothelium-dependent dilation with acetylcholine. That drug acetylcholine is going to go directly to the endothelium, cause the secretion of local vasodilators, and it's a good signaling of that endothelium-dependent dilation. And then the third one, we have our endothelium-independent dilation with sodium nitroprusside, which is just a chemical that will go and attack or communicate with the muscle directly and bypass any endothelium function. In vivo measurements here, we have flow-mediated dilation, passive leg movement, and dilation with nitroglycerin. I'm going to go more into the specifics of those in a bit. But for the ex vivo, the way that we measure our ex vivo measurements that we have here are by two different methods. We have wire myography and pressure myography. Wire myography is they take a wire and or two wires and they thread it through the artery, put it on the inside, and then they get the artery tight to a certain tension. And so that artery is being held up by these two wires, and then they will administer the drug. And if the artery dilates, then they'll see less tension on the wires, and they'll have force transducers to be able to tell how much it's taking force off the wires, or starts to constrict how much force it's adding onto the wires. Now, this is a well-established method. However, it's not the preferred, and the reason is it's very unlike what's in the body. In your body, your arteries aren't held up by wires and held to a certain tension, and you're not looking to decrease or increase in acting force. Instead, you're expecting the artery to grow and shrink in size. And so the other option that we have here is pressure myography, and this is used for smaller vessels. But what you do is you take the artery and you put it on a pipette tip in a machine that's going to send liquid flowing through it, and it's going to maintain the pressure of the artery, and so that this system will be maintained as if it was in the body. So these are our two methods. Pressure myography is going to be the one that we're going to be using. That's the preferred method that we have. Wire myography we will use if there is issues with making pressure myography work, such as vessel size. That's something that we can't control right now, but that's something that we are looking into. So in vivo measurements, these are measurements that we take from the person themselves, and we take it in person. We don't pull anything out of them, take it to the lab or anything like that. And so the in vivo measurements that we have, these are well established. We have flow-mediated dilation, which what you do is I know you really can't see me, but you take a cuff as they're laying down and you put it just above their elbow. You inflate that cuff to what's called a suprasystolic pressure, or it's above their blood pressure. And so it will cut off any blood flow going down to the forearm. And we keep it cut off for 5 minutes. It's not the most comfortable, but it's not going to kill you, not going to kill your arm. And so you're sitting there for 5 minutes. We'll be measuring the flow just above the cuff and the brachial artery. And as you release that blood flow, there's going to be as you release that cuff, there's going to be a sudden increase of blood flow as it rushes down to the arm. And you'll be able to see an increase of blood flow and an increase in the diameter of the brachial artery, all due to that flow and shear stress caused by the endothelium there. So that's flow-mediated dilation. Notice this is endothelium dependent, so it has that relation there. However, it is induced by flow mainly and not by any drug. For passive leg movement, it is also an endothelial-dependent dilation, but it's not associated with flow from the studies that we've been able to see. This is measured down in the femoral artery, but the person will be sitting in a chair and will basically just move their leg up and down for them. They don't move it at all. And the general idea is you're tricking the muscle into thinking it's exercising without increasing oxygen demand. So you're not getting any metabolites or signaling from the mitochondria saying we need more oxygen. Instead, it's just stretching of the endothelium and mechanical receptors that are going to cause secretion of what's called nitric oxide. Nitric oxide is a local vasodilator, and that's going to go and cause dilation. So we'll measure the increase of blood flow upstream from it, and that increase of blood flow will see how much that vasculature is dilating down there and how much more flow is going to the muscles. So this is shown to be at about 80% endothelial dependent. There's about 20% that's unaccounted for, but it is still one of the high standards of measurements for measuring endothelial dependent dilation without any kind of flow. And then our third option that we have here is dilation with nitroglycerin. That is endothelial independent. Nitroglycerin will go to the artery itself, to the smooth muscle itself, and cause dilation directly. And this will measure that dilation independently of that endothelial function. So the purpose of this study initially is to validate the comparisons between ex vivo and in vivo assessments of vascular function. In the process of research, you tend to lead up to the point that you can do human studies and to see the effects of things in humans. However, it is preferred that you have as much information, or it's required that you have as much information as you can leading up to the human trials to make sure that's safe beforehand and that you can generally know the effects. Obviously, we can't get that perfectly, but if we can validate these measurements to show that what is happening in the lab is what will happen in person, then we are much more likely to be able to see easy transition treatments of different drugs that can help with different diseases and such as that. So we want to be able to validate these assessments. And the use of the validated in vivo would also be to, instead of just transitioning from lab to person, in vivo would also kind of help us diagnose and use it more clinically. Flow-mediated dilation, passive leg movement, while they're good assessment of vascular function, they are not validated quite enough to be able to be used in a clinical setting or seen with standards in a way that's being able to use. So if we're able to validate those measurements in the comparison with the ex vivo, then it's going to be able to increase the use of those clinically. And then if there is disassociation, then what that will do is that will help us understand that maybe we are misunderstanding the mechanisms of how these treatments are working. Maybe acetylcholine isn't endothelial dependent as we read in the literature, or maybe passive leg movement has too many variables that we're working with that it's not actually nitric oxide dependent, but there's other things causing dilation. If we're not seeing correlations between things that we should expect it, then there's a lot more studies to come and understanding mechanisms and things like that. So for a hypothesis, I know it's a lot of words. I'm going to jump back real quick just to give an easier explanation. Our hypothesis is that each related measurement, ex vivo and in vivo, will have a correlation. So flow-induced shear stress and flow-mediated dilation, we'll see a correlation. Endothelium-dependent dilation with acetylcholine, passive leg movement, those will see a correlation. And the endothelium-independent dilation will see a correlation. So each of those three in those orders should see a correlation with its counterpart is our three hypotheses. We also hope to see, while not stated in our hypothesis, we would hope to see association between the endothelium dependent measurements in both ex vivo and in vivo, and be able to see a correlation between all and general vascular function, as that would be the purpose of all of them, is to see that vascular function. And our null hypothesis is that there would be no correlation in any ex vivo and in vivo assessments. So for our methods, in vivo first, we're still in the process of kind of understanding a little bit more of what we want to be doing. And so there's obviously variables in logistics. The preference would be able to have the subject come down, hopefully free of disease and medication, either to our lab or we go up and meet them at the hospital, and we would assess their flow-mediated dilation, passive leg movement, and administration of nitroglycerin. Those would be the key components, as well as what we would suggest for, sorry, let me scratch that. These would be key to be able to get right before surgery. If we had any time that we could, we would go right before surgery in a relaxed place for them to make these easy assessments. However, some things that we see with that is we'll see stress from the surgery, as well as if they have to be on any medications prior to the surgery, and if nitroglycerin is a contraindicator to be something that they would take on the day of the surgery. So we might have to go a couple days before the surgery, where they might not see that stress and they might not have all the qualifications. Logistically, that may be hard, but we can try to make it work. And if we need to, we can also do after the surgery and have them come into our lab on another day. However, that also would not be preferred. We rather get them as close and get their arteries as close to the condition that they would be as when they're also being taken out during surgery. Patients will be following the same protocol that they would for surgery, being fasted, rested, restrained from alcohol, caffeine, or other medications prior to the assessment. We'll assess, as talked about, the passive leg movement, flow-mediated dilation, and dilation in response to nitroglycerin in that order. If we do need to take nitroglycerin out, it's one of our lesser variables that we need, and we would just readjust to what we are able to measure. And all assessments would be performed with the standardized protocols from previous studies. Ex vivo. So again, this is what we take out of the body. During surgery, the surgeons will dissect a portion of the deep inferior epigastric artery. I did forget to mention on here, the surgery that's being performed is breast reconstruction. And so they're taking a portion of the abdomen and moving up as a flap for the breast. And on that, they have the deep inferior epigastric artery and vein. Now, they tend to be different lengths of what they dissect, and they rather have it be the same length for when they're reattaching it. So they automatically dissect a portion of that artery. And that artery will be transported in a PSS solution, a solution that has salts and glucose and everything that it needs to keep the cell alive. It will be oxidized, and that'll be transported to our lab, where we'll clean it, work to keep it alive, and be delicate with our process so we don't kill the artery, or especially the endothelium in there. And then we'll attach that to the pressure magnograph system. Our analysis will be, again, the standardized method for analyzing arteries in the pressure magnograph system, where we'll have it running in its bath. We will have it washed and rested between each analysis so that it's not affected by each one. SNP tends to have a longer effect, so we'll do that last so that we can discard the artery after and not worry about influencing the function. Once it is there, rested, relaxed, it's been there for a while, then we'll pre-constrict it to 70% of its previously determined maximum constriction with phenylephrine, so we get the artery down, and then we'll see the dilation due to the flow-induced shear stress. To do that, we just change the pressures of the fluid going through to about 30 millimeters mercury between one end to the other, which is going to increase that flow. That sudden sudden increase, or if we do a slow increase, either way, that increase in flow is going to cause that dilation there in the artery. Once we do that, we'll go and relax, let the artery get back to where it needs to. We'll constrict to the phenylephrine, do acetylcholine, and then repeat that process again for SNP. The diameter of these vessels will be measured by a computer software technology that's same with the pressure myographer. That's from DMT, where I'll be able to graph out the diameter on computer software as we are going. So our expected results, talked about this with the hypotheses, but that we expect correlation between the 3 pairs of measurements that are similar together. We also hope to expect a correlation similar between the endothelium dependent dilation methods, and that because all are measuring vascular function, we would expect a correlation between them all. However, with statistics, we'd hope to be able to separate these, because obviously if everything correlates with everything, then you really end up with nothing. And so we do hope to see stronger and stronger correlations depending on the type of assessment that we do. And those are the most important variables or correlations that we are looking for. So in conclusion, just in general, the study will be measuring vascular function, either ex vivo or in vivo, to determine the validity of the comparison between measurements, to be used in further progressing research, as well as validating on each side of the study. I talked about more of kind of the purposes of what happens if we don't. We need to understand more of the mechanisms if these are not correlating, and more research does need to be done there if what we find is not true. And also the validity of these can also help with using the use of these in clinical assessments. If you have any questions, let me know. Obviously, this is a pre-recorded. Go ahead, post your questions down below. And if you have any input or anything that you can make it better, we're still in the process of organizing this. So we're happy to take any input that you have. And thank you so much for listening.